Hello, today we're talking about contraception and abortion. I'm going to split this lecture into two separate video presentations just due to file size, so be sure to check the other presentation as well for the rest of the content. And since this is an online delivery module, the option for any further questions or anything like that, we're going to use Moodle or the Moodle forum as an opportunity to relay any questions that you might have, or you should also have access to my email if you have any particular questions to send my direction. So we will get started. So our overall lecture objectives, we're going to look at the mechanisms and actions of common forms of male and female contraception, rate efficacy and discuss the efficacy of different contraceptive methods, identify risks and benefits and potential side effects of various forms of contraception. And these are definitely conversations that you might have with patients. Definitely I do from time to time when discussing and giving education on patients on different options that they might have. We're also looking at abortion and identifying the appropriate gestational period for elective abortion, alternatives to elective abortion, and then surgical and medical abortion types as well. So those will be the main topic areas. This is a slide just overviewing the different types of birth control that we'll look at. So hormonal, we'll talk quite a bit about oral contraceptive. It's a pretty common method that you'll see patients on. So there's combined estrogen and progestin therapies or progestin-only therapies. There's also hormonal using local rings or patches, like the Nuva ring is a ring option, or transdermal patches we'll discuss. Depo-Provera is an injection, which is a hormonal therapy as well. And then surgical rod is also an implanted device that delivers hormones to help with contraception. IUDs, so intrauterine devices, we'll talk about the hormonal and non-hormonal types of IUDs. For barrier methods, there's a number of different barrier methods. So more permanent, like tubal ligation and vasectomy. Less permanent, like condoms, diaphragm, cervical cap, lace shields, spermicide, and sponges. So we'll discuss those all briefly. And we'll also discuss some other contraceptive methods like fertility awareness method, and lastly, to talk about abortion overall. And this slide is just overlying the different types of options we have for birth control and looking at them in different categories. So some more reversible, some less reversible or more permanent, and also looking at some emergency methods of contraception as well. So it's just breaking them down into the different types and how reversible they might be as well. Outer course is listed here in terms of reversible methods. Outer course is defined as other activities beside vaginal intercourse. And we'll definitely discuss basically most of these methods in more detail. So overall, how to choose or how you would, or things you would consider discussing with your patient in terms of helping their decision on different types of contraceptive. Of course, benefits and risks. Efficacy is definitely something you'd want to discuss and something that patients are wondering about in terms of how effective they might be. And generally those are recorded in pregnancy rates per 100 women. The cost of different therapies, some will be very cheap, some will be a little bit more expensive. Side effects, which ties into benefits and risks. And then any contraindications that might be relevant for your patient. Compliance, ease of use is definitely a consideration as well. And then personal preferences that patients might have as well. So starting off with hormonal contraception. So combination pills, so OCP combination pills, they have both estrogen and progestins. So progestins are synthetic progesterones. And how these work, estrogen will inhibit ovulation, and the progestins do a few different things to also prevent pregnancy. So it's thickening cervical mucus, making the sperm, or more difficult for the sperm to basically pass through the mucus and reach the fallopian tubes. It's also altering the uterine lining to make it more inhospitable for implantation as well. And basically supplying estrogen and progestin is having this mechanism on the body by inhibiting the release of the gonadotropins LH and FSH, which is basically playing key roles in the development of the egg and the uterine lining. So these are just some common brands of contraception OCP combination pills. So these are some brands that you might be familiar with already or may have heard patients discuss. Definitely there's other options out there, but these are some of the more common ones that are used in Canada. Another option for oral contraception is called the mini pill. So this is only containing progestin, so it doesn't have any estrogen in it. Because it doesn't have estrogen, it may not do as good of a job at inhibiting ovulation, although progestins do independently have a little bit of a role in ovulation. And the progestin is in a lower dose, generally speaking, than the contraceptive or the combined contraceptive pill as well. So it still is going to thicken cervical mucus, make the uterine lining more inhospitable to implantation as well. And a few common brands of mini pills include Micronor and NorQD. In terms of why practitioners might decide to recommend this instead of the other combination pill is typically certain health conditions that are cautioning or contraindicating the use of estrogen. So for example, if you have a patient that's high risk of blood clots, we'll discuss the contraindications or cautions for combined oral contraceptive, but that would be one concern where estrogen-based therapies might be cautioned or contraindicated. So that's one benefit of using something like the mini pill. It's not having estrogen, so it doesn't confer the risks that estrogen therapies would. So discussing again, the combination pills, we discussed that we're doing estrogen and progesterone for these. There's a few different types of combination pills. So most or the most common pills that are used are doing a steady dose of estrogen and progestin. These are considered monophasic combination pills. There are also options for biphasic or triphasic pills. So biphasic pills will have the same amount of estrogen in each pill, but differing amount of progestin in the pills. And then triphasic pills were the original form of OCPs that were constructed, and those had differing levels of both estrogens and progestins over the cycle. Those aren't used as commonly anymore, and overall with the research, there is not really any research to support that certain approaches are significantly more effective than others, but the monophasic is the most common recommended oral contraception at this point in time. So we discussed how estrogen and progestin is suppressing gonadotropins, which helps inhibit development of follicles, helps inhibit ovulation. Because of the lack of follicle development, that's inhibiting production of estrogen, and then the progestins are helping to thicken cervical mucus to make it inhospitable for sperm. So this is kind of mechanistically what we know is happening with the contraception pills. And the suppression of the gonadotropins is via the negative feedback loop that I'm sure you all are familiar with based on the normal physiology of negative feedback. For efficacy of combination pills, so they are quite effective if used properly. So with perfect use, it's based on data, it's 99.9% effective. Based on typical use in reported studies, so if they were doing observational studies on people using oral contraception, the typical use would be 97 to 99% effectiveness of preventing pregnancy, which is still quite effective. And generally speaking in studies, again, the rates of pregnancy that they're reporting on average is about 5 per 100 women with this type of contraception. In terms of benefits of contraceptive pill, so there's a number of potential benefits on hormonal related concerns, which is why they are quite commonly used. Of course, they're still used to prevent pregnancy as one of the common reasons, but you'll also, I'm sure, either through friends or family know this already, or personally, or eventually you'll see a lot of patients that also notice other reasons that they may be prescribed oral contraception. So oral contraception, because it's giving you consistent dosing of these hormones, does tend to induce a very regular cycle. Of course, not for everyone, and it kind of depends on finding the right birth control for some people, but it does tend to regulate cycles. So that is a reason that a patient might be recommended this. Decreases menstrual flow. So for people that are having really heavy periods, it will tend to regulate those a bit better. Decreased dysmenorrhea, so for people that are having a lot of pain with their periods as well. Acne, that is another relatively common reason that birth control might be recommended. if for problematic acne, if it's a hormonal component for sure there. And then PMS symptoms, again, which indicate hormonal irregularities. Birth control can be helpful for that. And in terms of studies on cancers, we do know that people using birth control do have decreased rates of endometrial cancer, ovarian cancer, and colorectal cancers. In terms of ovarian cancer, the research shows that women that use birth control for 5 or more years have about a 50% lower risk of developing ovarian cancer. And generally, they notice a greater reduction in that risk the longer the oral contraception is used. This, of course, is from observational studies. Why we think this is happening is birth control is reducing the number of ovulations that a woman is having in her lifetime, or follicle development that they're having in their lifetime. So reducing exposure to naturally occurring hormones is a thought on why that reduces risk. For endometrial cancer, according to the studies, the risk is reduced by 30% or more. And again, greater reduction the longer the birth control is used. And the thought in terms of why birth control may be helpful is it's helping to suppress endometrial cell proliferation, which makes significant sense as well. And for colorectal cancer, this one might be a little bit more surprising. So with colorectal cancer, overall, the studies support about a 15 to 20% decreased risk in observational studies. And birth control, one of the theories on why this might be helpful is that the estrogens can help to lower levels of bile acids in the blood, which is one of the theories on the protective benefit of colorectal cancer. Next, we'll discuss side effects of combination pills. So a lot of people do tolerate birth control quite well, but there are potential issues with certain side effects for patients. And sometimes if, contraception or oral contraceptives are the best route for a patient, you might have to explore and find a suitable birth control preparation that they don't experience side effects from. We'll discuss some of the side effects briefly as well. So this slide discusses some of the more common side effects that might happen with birth control. And a lot of these side effects may often subside after a few months of use. So that's also something that from an educational point of view, you would want to discuss with your patient. Of course, as naturopaths, we can help to manage these possible side effects through some supportive therapies as well. So that's something we could consider doing in the meantime. But things that we might see more commonly, so breakthrough bleeding or spotting, definitely might happen, especially initially with the pill. Headaches, so general headaches, migraines as well. Some patients will notice an increase in migraine frequency when they start birth control. But conversely, some people actually notice, very much of an improvement with their migraines with birth control if their migraines are triggered by fluctuations in hormone levels. So it could go either way with migraines overall. Breast tenderness might happen initially for sure. Nausea is a relatively reported or commonly reported side effect. Weight changes are reported in the literature. Typically, they're pretty minor overall, not too significant in terms of the amount of weight gain. And mood swings also falls into this category as well. So those are some of the more common side effects. Some other side effects that are reported less commonly but could be relevant, decreased libido, hair loss. Those both would be partially because of the influence of hormones on the birth control. Blood clots is the one that a lot of people are most aware of with birth control, and one of the more concerning side effects, of course. And we know part of this is the estrogen and the combination pill that's inducing this increased risk. So blood clots definitely, the risk isn't common, but it's definitely a rationale for being very careful on who we use birth control in, especially women with an increased risk of blood clots. So that would be something to be very aware of. Can increase blood pressure in some cases, so monitoring blood pressure in your patient would be relevant, or if someone already has elevated blood pressure, it would be a little bit more relevant to prudently monitor. Elevated liver enzymes is, possible. Generally, it's not too significant again. Increased risk of cholelithiasis or gallstones. Definitely that's also something that's reported in the literature as well. Vaginal infections, potentially, we'll discuss that in a little bit more detail, but There is actually some evidence as well showing that the risk is decreased with combination pills. So it's a little bit conflicting the literature there. And the last thing in terms of cancers, we discussed a few benefit or protective effects of birth control, but in terms of increased risk of cancers, breast cancer and cervical cancer are the two that seem to be associated with combination pill in terms of an increased risk. And why we think breast cancer and cervical cancer, the risk is increased, is due to the proliferative effects of these hormones on these tissues. So that's definitely one of them. And then we also think that birth control might increase cervical cancer risk by changing the susceptibility of the cervical cells to infection with high-risk HPV. So that's another theory on the oral contraceptive cancer or cervical cancer link. So just discussing breast cancer risk in a little bit more detail. There was a meta-analysis done that looked at over 150,000 women, and they found a slight 7% increased relative risk of breast cancer if they've ever used RCP, if a patient had ever used OCP. And then they found with the same meta-analysis that women that were currently using OCP had a 24% increased risk. Overall, the risk they found declined after stopping birth control. And over 10 years of abstinence or disuse of birth control, they found that there was no increased amount of risk of breast cancer. So that's something to consider when you're discussing, this potential risk with your patients, is that it appears that this risk does decrease significantly over a longer time of disuse of the contraceptive. And oftentimes with birth control, we are using it in a fairly young population when, generally speaking, they shouldn't have a high risk of breast cancer. So that's just some information in terms of the research there. Another study looking at Nurses Health study found that there was a higher risk of that increases your breast cancer associated with the triphasic pills, which are the older types of birth control versus the newer types. And then there was a recent 2017 prospective study, a Dutch study, reporting that the increased risk was with more recent formulations, so almost conflicting information, averaging a 20% or so increased risk. So overall, that's summary on some of the research on breast cancer. For cervical cancer, based on the studies, it seems that longer use of birth control confers a greater risk. And then one study found about a 10% increased risk for less than 5 years of use. But if you're using for 5 to 10 lines, it was about a 60% increased risk. Again, they found with this research that the risk seems to decline over time once the women are stopping birth control as well. And we know that with these types of cancers, if you're still using birth control or your patient's using birth control, there are certain ways of preventative detection. So with cervical cancer, doing pap testing, with breast cancer, looking at other types of preventative screening. So just moving on to next slide. So we discussed already one of the more concerning risks was clotting for combined oral contraception. So in general, contraindication for oral contraception pill is not to be used in them for female smokers over the age of 35. So increased risk independently confers increased risk to clotting, but especially smoking or the combination of the two is putting that population at higher risk of blood clots with birth control. So this is a population where you would discuss other forms of contraception instead of using a combined oral contraception. For discussing some other benefits of birth control to consider. So one would be spontaneity. So birth control is done, as a daily dose that the female would take, but it doesn't influence the process of sexual arousal or intimacy. So that's definitely one thing that's a benefit. The mini pill can be used during breastfeeding because it's a progestin-only therapy. So that's a benefit if someone was breastfeeding and wanted contraceptive devices. It is reversible, so you can stop taking birth control and you can get pregnant again, for example. And we talked about the decreased risk in ovarian cancer and endometrial cancers. These are some other statistics on that as well. Birth control can also be helpful for ovarian cysts. So functional ovarian cysts are cysts that develop in response to certain hormonal changes in the body. So because it's helping to balance hormones out, can help with eliminating functional ovarian cysts, especially if they cause complications like pain or other symptoms for the patient. Helping to suppress endometriosis, again, partially because of the hormone balancing effects, and helping to decrease overproliferation of endometrial tissue. Someone with endometriosis can notice some symptomatic improvements on birth control. For PCOS, OCP can help reduce androgen overdevelopment, so can help with PCOS in terms of some of the symptoms. So for example, can help with cycle regulation or with excessive hair growth or acne in relation to PCOS. And with women that have STIs, they have found in the literature that OCPs tend to be more fertility sparing in the sense that you're less likely to develop pelvic inflammatory disease if you're taking birth control and have STIs overall. So one study, which is part of the Women's Health Study, a prospective study, found a 50% reduced risk in development of PID for patients on OCPs that had sexually transmitted infections. OCPs, other things to consider that might be, cons of OCPs. It does require a prescription. Not that it's overly difficult to get a prescription for birth control, but that's something that a patient would have to get to have access to. It's not protecting against sexually transmitted infections, including HIV. So definitely you'd want to educate your patient on that and talk about other forms of protection in that manner. It's not immediately effective necessarily. It depends on when you're starting taking the birth control pill. So if you start combination pills within the first 5 days of your cycle, so from days 1 to 5 of your cycle, which is generally when most people are having their period, it is immediately effective based on the research. So you don't necessarily need to use a different form of contraception as well. But if it's not taken in the first 5 days of your cycle, it's recommended to use a backup birth control for the first 7 days. Condoms or something of that nature. We discussed, some possible side effects or contraindications of use as well. And one of the other, potential downsides is consistent daily usage. So it's less effective if it's not taken at, a consistent daily dose. So that could be a challenge for some patients, is the compliance factor in terms of the effectiveness. So other considerations on, potential risks, a lot of people do wonder or are concerned if there's any influence on their fertility long term or returning to a regular cycle after coming off of birth control. Surprisingly, there's a lack of research in this area. There are some studies, but there's not as robust amount of research as you would almost expect, given the level of concerns that people have over this. So there was, a few studies on this overall that are generally, again, observational studies. This one study that's referenced here was looking at 198 women and found overall out of the 187 that completed the study, most of them, so 181, returned to menses and 4 became pregnant within 90 days. So in the meantime, to return to menses was 32 days. So generally finding, pretty quick return to periods again. Didn't seem to be any overt or any significant issues with fertility based on this study as well. Another study that was looking at BBT charting or BBT tracking post birth control found about 10% didn't ovulate in the first cycle post birth control versus 3% in a comparison. So seeing some influence possibly on the first cycle on ovulation. But again, like I discussed, there's not, a ton of research in this area, but based on the research there is, it doesn't suggest any significant impairment on return to menses or long-term fertility. Of course, you will see, and I've seen in practice, some patients that are exceptions to this, where they are having a delayed return to menses, or other symptomatic things like that. So there are naturopathic ways that we can help to support this if people are coming off of birth control and aren't having a return to regular cycles. Sometimes people revert back to their old patterns. So if they remember having very regular cycles before starting birth control, it's not uncommon to see people revert back to this pattern after stopping birth control again. So just some overall considerations, but it doesn't seem like a huge concern in terms of return to some type of menstrual picture or fertility. And this is just a study, or the abstract on a study, that you can review in terms of that discussion. Other things that are briefly reported in the literature in terms of potential risks. Some studies looked at thyroid and reported that TSH values could become elevated for those on birth control. This may or may not be significant clinically. So we know that estrogen physiologically can increase the levels of thyroid binding globulin, which can make less free T4 available to the tissues. So there is, reports for people that are on, for example, Synthroid for hypothyroidism, or people that have thyroid conditions, that they may need adjustments in the management or dosing of their medication when they go on birth control, if the thyroid doesn't naturally adjust their hormone production after being on birth control. There was a double-blind randomized controlled trial that I looked at that found increased total serum T3 and T4 values, as well as increased TSH values, but overall not any long-term change in the free T3 or T4 after the first cycle. So it doesn't necessarily seem like this is overly significant, but something to consider, that birth control and the hormones that birth control offers might influence the thyroid in some way. So it can be something to monitor. Liver tumors. So there is some report of benign liver tumors developing with birth control. There is conflicting research on this as well, but there is some association between birth control and something called hepatic adenoma, which is a non-cancerous form of a liver tumor. So just something else that's out there. And increased sex hormone binding globulin. So looking at a retrospective observational study, this found that sex hormone binding globulin levels in contraceptive or contraceptive pill users were 4 times higher versus those that never used oral contraceptive. When they monitored after people stopped taking birth control, they found that the sex hormone binding globulin levels did decline again, but they did remain higher than those that were never using birth control 120 days, so 4 months after stopping birth control. So in terms of why this might be relevant clinically, one thing this makes me think of is this could be related to the rationale for some of the side effects of birth control, but definitely worth noting that this might have some indirect influence on hormones as well, and possible side effects. So we already discussed the increased risk of breast cancer. So I think I mentioned most of this already, but it increases with current or recent use. Rates decline to normal after 10 years of cessation. And then it appears that the risk is highest among women who start as teenagers, because this might be, or the theory is this might be a critical time for development of breast tissue overall. And here's another reference that you can peruse yourself to look at that in a bit more detail. I mentioned briefly vaginal infections. So for vaginal infections, it does appear in some studies that birth control pills might have a minimal effect on vaginal flora. For example, small decrease in lactobacillus based on a 2-month follow-up study. But actually a lot of studies, or more recent studies, looking at birth control use found that the risk is actually decreased of at least bacterial vaginosis with birth control use. So again, conflicting information, but something potentially to keep an eye on with your patient. And here's just a few studies you can read for risk of vaginal infections. Drug and natural product interactions. So these are a few of the more significant interactions between birth control and drugs or natural health products. So St. John's wort we know has one of the higher risk of interactions in terms of the herbs we're aware of. This is increasing CYP3A4 activity in the liver, so it'll shorten the half-life of estradiol and might make birth control less effective. Antibiotics interact as well. Seizure medications and protease inhibitors used for HIV therapy are some of the bigger ones that you want to be aware of. Some other considerations, potentially more from a naturopathic perspective for birth control. One is that the pill can deplete certain nutrient levels. Some of these are more significant than others, but I've listed here any of the possible, based on the research, depletions that can happen in nutrients from birth control. So folic acid we know is important for cervical health, DNA replication, detoxification, a number of the B vitamins, so B2, B6, on the next slide you'll see B12 as well, are all potentially depleted in some significant manner. So for that, we think about things like energy production and metabolism, fat and carb metabolism. B6 is involved in serotonin production pathways. B6 deficiency is associated with increased risk of blood clotting, so it might have some relevance in terms of that risk factor. For B12, again, energy and metabolism are things we consider with that. Vitamin C and vitamin E, not necessarily too significant, but could be depleted. So we could see some decreased levels of both of those. Vitamin E is involved in platelet aggregation, so potentially could be implicated again in that increased risk of blood clotting. Magnesium, so magnesium could again be related to the blood clotting risk, but that is a possible side or depletion as well. Selenium can be potentially relevant, and zinc is again a possible reduction in risk. So some of these might be more or less significant, but these are some of the nutrients to be aware of that there may be depletions of. Another potential consideration, and there's not a lot of literature on this, but there is some report of this, is potentially influencing digestion and causing more of a dysbiotic picture. So estrogen we know impacts gut permeability and bacterial balance. So there is some evidence suggesting that birth control pill can be linked to symptoms of gas, bloating, IBS, and an increased risk of Crohn's disease in women with a family history of Crohn's. So the reference here at the bottom is discussing that literature a little bit more in detail, but could be another thing to keep an eye on with your patient overall. Another consideration is endometrial lining, or the effect of OCP on endometrial lining. So there is some research to suggest that long-term use of birth control could lead to a thinner endometrial lining that could persist beyond cessation of birth control. And this is thought to be due to downregulation of the estrogen receptors in the uterus, resulting from long-term use of the synthetic progestins. This is also the same mechanism of action that we associate with birth control and the decreased risk of endometrial cancer, which is a protective thing. There was a study done in 2012, 137 women in a fertility clinic. They were undergoing a frozen embryo transfer. And in this study, which would be observational in nature, they found approximately 63% of users in the thin lining group had been on oral contraceptives for more than 10 years, compared with only 28% in the normal lining group. So some suggestion potentially of a link between birth control and thinner lining, but again, a more observational study. There is also some research from animal studies, so studies in rats showing that long-term synthetic progestin use, they find the number of estrogen receptors in the endometrial lining decreases. So that's what we're thinking from a mechanistic point of view. So just another thing to be aware of. One of the more general naturopathic considerations that I think are relevant is birth control doesn't necessarily address root cause. So the pill, our birth control pill, is used as a primary treatment from a conventional medical perspective to treat many female reproductive issues without necessarily properly addressing underlying concern or underlying cause. So when the pill is discontinued, often the underlying imbalance may still be present, but the patient is just older. So naturopathically, there's a lot that we can definitely do to address some of the underlying or root cause a little bit better. So that's something else that we can offer that can be very substantial in terms of managing symptoms if we're talking about using birth control to manage symptoms versus just act as a contraceptive mean. Another type of oral contraceptive is called DIN-35. This is a combination of estrogen and an anti-androgenic hormone. And this is oftentimes prescribed for women with acne and or more of a PCOS diagnosis. So this, and as of 2005, Health Canada had a report coming out with DIN-35 saying that it must not be used in women with thrombophlebitis, thromboembolic disorders like blood clots, or a history of these conditions, because they found that DIN-35 had an increased risk of blood clots, even compared to the typical combination OCPs, and also suggesting that it shouldn't be used for purposes of birth control alone. So, suggesting that you use the general combination OCPs versus DIN-35 based on this increased risk that they're seeing. Also suggesting, or based on the guidelines, saying that oral contraceptives should not be taken during treatment with DIN-35, which makes sense as well because birth control, or because DIN-35 provides similarly effective birth control as other types of oral contraceptives, so you wouldn't really need to be on both. DIN-35 should be discontinued 3 to 4 months after the signs of acne have completely resolved. So suggesting, again, based on the increased risk, not to use this as a long-term therapy. And cigarette smoking, of course, increases risk, as does increasing age. So again, the blood clotting is the main factor, or the main caution that we would have with this. Other types of OCPs, so there are extended cycle OCPs. So Seasonal or Seasonique are two of the brand names of this. And with this, you end up having 4 menstrual cycles per year and 91-day cycles. So you're having 84 days of the combination birth control pills and 7 days of placebo. For this type of birth control, there was a 2-year study done to evaluate the risks beyond the regular type of oral contraceptive. So this was 189 women. This reports some of the more common side effects that we're seeing. They didn't find any reports of endometrial hyperplasia or carcinoma, which you could potentially be worried about with delayed or longer cycles. So that was good to see. For other side effects potentially, they found spotting can occur, but usually decreased, or this spotting decreased to the regular birth control use by the 4th cycle or so. So maybe a little bit more spotting than regular OCPs, but that does tend to decline over time. There were a few serious adverse events reported, but they were finding only the cholecystitis and the bile duct stones was likely related to study medication. No thromboembolic events, so no clotting was reported, and impairment or return to fertility was not greater than the typical 28-day birth control. I mentioned there's also a few other types of deliverance methods of hormonal contraception. So transdermal patch, which is often called Evra, is an estradiol and a synthetic progestin as well. This is the same mechanism of action as the pill in terms of how it works. The patch is replaced weekly, and so you're having a patch for 3 weeks on, 1 patch a week, and then 1 week off for this. Another option is a vaginal ring, so Nuva ring. So this is a flexible ring made of a copolymer. This is releasing a constant dose of estradiol and progestin. So it's used for 1 cycle for 3 weeks, and then it's removed for a week afterwards. And again, same mechanism of action as birth control pills. For the ring and the patch, benefits of this, these are again reversible forms of contraception. They're done once weekly or monthly, depending on the ring or the patch application. So you're not having to take a pill every day, which might be a benefit for some people. It does help, again, similarly to the birth control pill, at decreasing some of those hormonal symptoms or concerns like dysmenorrhea. This doesn't, again, affect spontaneity with sexual intimacy, so that definitely is a benefit, and can help to, again, regulate cycles and decrease PMS symptoms and those types of concerns. The risks or the cons are similar to birth control or contraception because, again, we're still delivering those hormones. Additional risks or cons would be skin irritation for the patch or detachment of the patch or dislodgement of the ring. So those could be potential issues. The patch does have slightly higher estrogen levels. So there is a little bit of a higher risk of clotting with the patch. So that's one thing to consider. And the other thing that we know with the literature about the patch is that it's not as effective for women that are weighing over 198 pounds. So the study found, or some studies have found, increasing pregnancy rates in the patch for overweight or obese women. And there's a few reasons why this might be the case in terms of metabolic influences on hormones for this, but that's something else also to be aware of for this type of birth control. For the NuvaRing and the patch, so with perfect use or method failure, efficacy is quite good. So, 99.7% effective. Average use or typical use, the failure would be 8%, so that would be 92% effective. And pregnancies per 100 women was reported at 5 based on the studies. As a summary for contraceptive or hormonal-based contraception, this is a slide listing absolute contraindications for estrogen-containing contraceptives. So venous thrombosis, pulmonary edema, coronary vascular disease, having stroke in the past or a history of stroke, current pregnancy, breast cancer within the last 5 years, definitely associated with that increased risk of breast cancer or endometrial cancer. Hepatic tumors or abnormal liver function could be a contraindication for sure as well, considering that suggestion of increased liver function issue, or not liver function issues, but liver tumors or those types of concerns. Abnormal uterine bleeding, at least until we identify the cause of the abnormal uterine bleeding, just to rule out endometrial cancer being involved. Age over 35 and smoker, we discussed the increased risk of blood clotting and uncontrolled hypertension, at least until that's better addressed because of the increased risk of blood pressure increases. For injection hormonal contraception, there's something called Depo-Provera. So this is a single IM injection that's done every 12 to 13 weeks of DMPA. This may prevent ovulation, but as being a progesterone, we do know it thickens cervical mucus to prevent sperm from penetration, changes endometrial lining to prevent implantation. So those are similar mechanisms that we've already discussed for progesterone-based therapies. And after discontinuing the injections, based on the literature, pregnancy can occur as early as 9 months after discontinuation. Benefits for the injectable. So it's effective immediately as a form of contraception. There's no estrogen with this therapy, so we don't run into the cautions or contraindications with estrogen-based therapies. It's administered only 4 times a year. So that's, again, like more of a benefit from a compliance perspective. It is okay for breastfeeding women because it's progestin only, and okay for smokers because of the lack of estrogen. And, symptomatic benefits for patients. We do find it is helpful for a lot of the functional hormonal concerns people might have, like painful periods, endometriosis symptoms, ovarian cysts, endometrial cancer risk. So risks or cons, amenorrhea or absence of periods. Some may find this a benefit overall, but that could be a risk or con. Not, again, protecting from STIs or HIV, so you'd want to use a different form of contraception for that or protection for that. There is a bit of a delayed return to optimal fertility, so might not be the best option for someone that's thinking about having children in the near future. Can be, again, irregular bleeding happening or spotting. Weight gain is a possible reported side effect. And one, unique thing about Depo-Provera in comparison to the rest of the things we've discussed is bone loss. And the theory behind this is that it does induce a bit of estrogen suppression, and the protective effects of estrogen on bone can be decreased from this. So it's something also to be aware of if someone is thinking about using Depo-Provera, is thinking about bone health as well. Efficacy, so perfect use, the method failure is 0.3%, so quite good. User failure is about 3% typically. Not seeing huge differences there because we're relying on someone else to inject, so there's probably not a huge issue with compliance or anything of that nature. Pregnancy per 100 women is 1. Mid-range in terms of cost and ease of use. It does require office visits, so that's something to consider in terms of the injection. Another method is an implant contraception, so birth control rod. So there's a few brand names, including Nexplantin and Implantin. This is progestin releasing rod, so we're not having estrogen therapy with this either. It's implanted under the skin of the upper arm typically. And again, because it's a progestin, it will thicken cervical mucus, altering the lining, and may prevent ovulation as well in terms of how it's helping with contraception. Benefits with this, it's also immediately effective, no estrogen again. It is effective for up to 3 years, so you can have the rod inserted and don't really have to do anything for up to 3 years. It's okay in breastfeeding because of the lack of estrogen, and it doesn't appear, based on the research, to induce bone loss like Depo-Provera does. So that's an additional benefit between those two therapies. It is, again, helping with potentially painful periods, endometriosis symptoms, ovarian cysts, endometrial cancer risk. And then overall, people notice that they tend to have lighter and fewer periods with the rod. So after 1 year, 1 in 3 women will stop having irregular periods. So a lot of people do find that a benefit, especially if their periods are not so pleasant in terms of symptoms. So that might be an additional benefit. Risks or cons, we discussed already that amenorrhea picture is possible. No HIV/STI protection. Again, there is a delayed return to optimal fertility, similar to the Depo-Provera. Irregular bleeding can definitely happen. There could be local issues like infection or pain at the site of injection. Ovarian cysts is a possible reported side effect as well. There is some reports of change in sex drive, libido as well with this. And this isn't suggested to be used for women who have had breast cancer based on the literature as well. Birth control rod, 99% effectiveness. 1 per 100 women get pregnant with this method. Some typical side effects are, again, because of the hormonal influences, some mood changes, weight gain, acne, headaches, those types of things. It's about a mid-range cost and quite easy to use once inserted. So it just requires the office visit to insert, and then you really don't have to do much for a while. So pretty easy to use overall. And next we'll talk about barrier forms of contraception. So starting off with the irreversible methods. So vasectomy. Vasectomy is a day surgery to completely occlude the vas deferens bilaterally, and this will help prevent sperm from entering semen. So this is the male form of irreversible surgery. This takes about 30 minutes. They'll use a local anesthetic, and there's a few different techniques they'll use. A conventional approach is to use a scalpel to make an incision in the scrotum. No scalpel technique will locate the vas deferens through the skin, and then they use a clamp and then a forceps to puncture the skin. And basically the vas deferens is occluded one of a few ways, cauterized, cut, or tied, so that eventually there is no sperm entering semen, and that will provide irreversible or hard to reverse contraception. And so for tubal ligation, I don't think I actually put a slide on this, but tubal ligation is the female version where we are tying, quote unquote, the fallopian tubes. So it's again a local surgery. that bilaterally blocks the fallopian tubes so that you don't have egg or an egg being released into the uterus. So again, that is providing a more irreversible form of contraception from the female's point of view. So benefits of either vasectomy or tubal ligation. This is permanent. That's definitely a benefit if that's what you want. It is inexpensive over the long term. So there's an expensive front, but long term it is inexpensive overall. Fairly simple procedure, day surgery, no hormonal side effects because we aren't influencing hormones in any ways. For risks or cons, it's permanent. So that could be a risk or a con if you if someone was to change their mind about wanting to have children or not be so certain about that. It does require surgery. It is a surgery, so that is a risk or con. There can be local effects of surgery, post-surgery, like pain or swelling at the incision site. The reversal is not guaranteed necessarily, so that's definitely worth considering. It does not protect against any STIs or HIV, of course, so that's also something you'd want to consider additionally, and it's not immediately effective. So with this type of procedure, they will recommend another form of birth control used, for example, for the vasectomy, at least until all of the viable sperm that remains in the tubes are gone, and this process can take a few months. So there might be a few months of using a different form of contraception, like barrier protection, for example. For effectiveness, vasectomy, method failure of 0.1%. For tubal ligation, method failure of 0.5%, and pregnancies per 100 women is 1 for either method. So quite effective overall. And now discussing reversible forms of barrier contraception. So male condom, latex or non-latex sheath, which prevents the passage of semen into the vagina. This is, a very common form of birth control that a lot of people do use. There's also a female condom, which is not as commonly used. This is latex or polyurethane, typically, again, a sheath, but this is placed in the vagina, and it's generally placed before intercourse. It can be placed there up to 8 hours before intercourse overall. And for the vaginal condom, there's a ring at both ends. The closed ring will fit over the cervix, basically, while the open ring will rest outside of the vagina and covers the vulvar area. So this is an image showing or depicting the female condom and how that would look anatomically in terms of its orientation. Male condom benefits: very easy to access, no prescription required. It does offer STI and HIV protection, so that's one of the benefits that a lot of the other methods we've talked about so far do not have. A low cost, there's no hormones involved, so no hormonal side effects. It's immediately effective. Also from a sexual dysfunction perspective, it may prevent premature ejaculation if the male is having any difficulties with that, so it's kind of a side benefit for the male. Risks or cons: there may be pressure to keep erection or ejaculate within the condom from the male's perspective. May dull sensation, so that's one of the more typical concerns with this type of form of contraception. It does or could interrupt intercourse in some way because you're having to put on a condom, so that is again potentially a con. And latex allergies, although there's a lot of options there as well. Efficacy, so method failure or ideal use would be 2%, but general user failure is about 15%. Pregnancies per 100 women is 11 to 16. We talked about it's very inexpensive, easy to moderate, ease of use, just requires the patient to be aware of proper usage, basically. Just a note with male condoms, so oil-based lubricants that are containing alcohol could weaken latex and cause it to break. So if you're using a condom, these are some things that you would want to avoid using in terms of lubrication to preserve the integrity of the condom. So there's just a list here of some things that you would not want to use as lubricant. For female condom benefits, a lot of things similar to male condoms, so no prescription, does protect against STIs and HIV, no hormonal effects. It's immediately effective, reversible. With this one, you can insert it up to 8 hours before intercourse, so that could be a benefit. And it's okay for breastfeeding and smoking women because there's no hormonal effects. For risks or cons, it may be uncomfortable or a bit noisy during intercourse. It's more expensive than a male condom. It's more messy than a male condom as well. It doesn't hold semen in the same way that it does for a male condom, and may also irritate mucous membranes as a possibility. The method failure of female condom is 5%. The user failure is about 21%. And pregnancies per 100 women is 20, so a little bit less effective than a male condom. It's more expensive than a male condom, and again, easy to moderate ease of use overall. So another form of reversible barrier contraception is a diaphragm. This is a latex dome that's positioned in the vagina, fits over the cervix to prevent the entry of sperm. It's used with a spermicide and cannot be used with oil-based lubricants, again, for similar reasons to the condom. Diaphragm requires a fitting by a healthcare provider because they do come in different sizes. So that's just something to be aware of as well. Something somewhat similar is a cervical cap. So a cervical cap is a thimble-shaped silicone cap, which is positioned over the cervix to prevent entry of sperm. This is also used with spermicide, and again, cannot be used with oil-based lubricants for the same reason. And this also requires fitting by a healthcare provider to ensure the proper size. For either the cervical cap or the diaphragm, both must be left in place for 6 hours after intercourse for it to be most effective. And this is basically because it's a barrier contraceptive, it's preventing passage of sperm, so it needs to be put in place for a decent period of time after intercourse to continually prevent sperm entry through the cervical canal. So here's some images. This image here is of the diaphragm. So what the diaphragm looks like, how it would be positioned over the cervix. And then the next is a cervical cap. So again, something that is occluding the cervical opening to preventing sperm from entering uterus. A few other methods of barrier contraception. So this is the next one we'll discuss is the lace shield. This is a silicone device that's inserted in front of the cervix again. So it's again acting as a barrier to sperm. This is reusable, similar to the other two devices we've discussed. Offers about 8 hours of protection and can be inserted in advance. This doesn't protect against STIs. And the failure rate is about 12 to 18.7% with spermicide. So this is just a picture of the lace shield as well. So for cervical cap, diaphragm, we're talking about some of these reversible barrier methods. Benefits, there is no hormonal side effects because we're not using hormones. It's immediately effective. It's very easily reversible. It's okay for breastfeeding and smoking women because, again, there's no hormones. It's inserted before intercourse. There's no interruption of sexual intimacy. And there is some STI protection. So there is some protection against chlamydia and gonorrhea. But of course, there isn't full protection on all STIs because there definitely is still exposure to genitalial tissue and other things like that. So you can definitely still be at increased risk of a lot of STIs. For risks or cons, both the cervical cap and diaphragm require a prescription. They do require a proper fitting. There is an insertion learning curve as well, so that's something to be aware of. It's possible for there to be skin irritation with these forms as well. The protection for STIs is very minimal. There can be an increased risk of toxic shock syndrome, so this is something to be aware of and making sure the patient's using them properly. An increased risk of UTIs are also reported with these forms as well. And also potentially concern of it becoming dislodged during intercourse. So that could be worth noting as well. For cervical cap and diaphragm, method failure or ideal use is about 6%. Typical user failure is about 16%. And pregnancies per 100 women is 15 to 23 or so. Moderate in terms of cost and moderate in terms of ease of use. We did discuss there's a bit of a learning curve with this device overall. And then we already briefly talked about this as well, but other things that are reversible that act more as barrier contraception are things like foams, jellies, creams, sponges, and films. You can also have lubricants that are containing spermicide. So with spermicide, it's inserted into the vagina, used potentially with other barrier contraceptions and containing ingredients that are disabling sperm. So we talked about spermicide being used with the cervical cap or diaphragm. So that would just confer some additional benefit or additional protective benefit as well. So spermicide must be used with the cervical cap or diaphragm for effectiveness. They should not be relied on alone overall, but there's different forms or preparations of doing a spermicide. Overall, this image is looking at a film as one of the options. For benefits of spermicides, no prescriptions required, they're inexpensive, they're easy to use, there's no hormonal side effects. It's again immediately effective, it's reversible. It can provide extra lubrication as well, which could be a side benefit, and can be used during breastfeeding and for smokers because there's no hormonal effects. For cons or risks, there is a high failure rate if these are used alone, or spermicides are used alone, so it's generally not recommended. Messiness, in terms of, depending on the type of or form you're using, there is some messiness to it. There can be skin irritation based on the ingredients in it, so some people might not tolerate them well. Could interrupt intercourse as well, and no STI or HIV protection. So the spermicides, perfect use about 18% method failure, user failure is about 29%, and pregnancies per 100 women is 30 with this use alone. And cost is very low, similar to condoms, very easy to use overall. Okay, so I'm just going to stop here just to make sure my file is not too large, but we'll continue on with the next video with the rest of the material, continuing on with IUDs.